Dr. Bradley Bush in the house. What is going on, my friend?
Hey, Roland. I'm hanging out with you on the podcast.
You poor man. You had nothing better to do this evening.
Yeah, well, I just got finished with a day of patients. I'm still in my examination room number 3. But hey, I'm looking forward to having some time with you.
Well, we want to thank you for being here. I mean, we haven't done one of these in a couple months now, and the master class is literally my favorite thing of education for education's sake, letting an expert in their respective field and discipline just tell us what it is that they're passionate about, how they look at things, how they have success. So I know you're busy. You've had a long day, so I want to thank you for dedicating some time to this at the end of your day. I always start off these interviews the same way. And I think it's really important to know the person and the personality behind the information. So if you wouldn't mind, I want to ask you, what's your backstory? How did, Bradley Bush, ND, become master of slaying SIBO? 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 We talked about that before.
Yeah,
Anyway,
tomato.
yes.
It's wherever you want to go with it. It's all good.
Right.
So, well, my backstory, I'll just go back to the very beginning. I mean, after conception, I did grow up. I grew up in the south suburbs of Chicago. I got introduced into kind of biology by my mother. She was trained. She was federally and state licensed to handle animals. And my father, who worked for Ford Motor Company, was a tinsmith. They took half of our basement and our garage and turned it into an animal refuge center. So I got to grow up with injured and orphan animals. You kind of raise them, you nurture them, you take care of them, you acclimate them back to the outside world, and then you let them go. And so now this was the cookie cutter south side of Chicago. I wasn't in the farm area. I was like in suburbia doing this. So we were that weird family. So I'm okay with that. I grew up that way. We grew up mostly vegetarian because of that. And later on, of course, what did I want to do when I grow up? I wanted to be a vet or a researcher. So I ended up going into zoology, got myself a minor in chemistry, fell in love with genetics and neurobiology. Thought I was going to go down that research path, kind of threw some applications out for master's programs in those fields. And lo and behold, I ended up volunteering with a meditation yoga society group that I was part of. Ended up in Haiti for 6 weeks, where I worked. I lived in an orphanage and helped teach English, yoga, meditation, and write grants for food cooperatives and an orphanage and a school. So I quickly learned in that process that, well, maybe this world doesn't need another researcher in a windowless room, and maybe I needed to actually help man and womankind. So at that point in time, I was basically pre-med with an advanced science degree in my choices of classes. I did not want to go into conventional medicine. One, because I didn't want cookie cutter medicine. I didn't want to go work in a hospital where people said, just fix me without having any skin in the game. I wanted to work in a more holistic manner, something that I felt strong about. So I was researching programs at the Tinley Park Library, the Barrett's Guide to Graduate Programs. And I didn't know, I'm from the south side of Chicago. I don't know what a naturopath was, but I was looking for acupuncture, chiropractic. And of course, I wanted to just go somewhere where I wanted to live. So I'm looking out in the Pacific Northwest, California. I dropped the book. It opens up to naturopathic medicine. I make a few phone calls. I'm on my way to Oregon to live, and I ended up going to National Naturopathic College there. In my journeys, I ended up working within the industry right off the bat, both in private practice and with one of the largest supplement companies in the country for physicians. Got to learn a little bit about the business on that side of things. Ended up working with a commercial and research laboratory that also had a supplement line for a number of years as an executive. they moved me from the East Coast of New Hampshire to, God forbid me, like back to the Midwest in Minnesota. And after 7 years of doing that, I decided I didn't want to play the corporate game anymore. So I opened up my private practice again. And it was about a year and a half into that I realized that, this thing called small intestinal bacterial overgrowth had become a much more popular, well-known item. And there was lab work you can do. So I'm ordering all these labs. And well, with my background in the lab industry, I just needed an excuse to then buy the machinery. So I got some machinery for doing the testing. And lo and behold, once you buy it, they come. Obviously, the brain-gut connection has been something that I've been passionate about from day one of practicing, and then having some type of qualitative measurements to back that up and to help in guidance and to fine-tune diagnosis and treatments was wonderful. And so I was able to incorporate that in many different facets, from seeing how that plays out with all of your typical chronic GI issues to acute GI issues to chronic fatigue fibromyalgia to, of course, looking at it with the group of people with chronic diseases, whether they are actually diagnosed with those diseases or just kind of have that name attached to them. Especially here in the Midwest, we have Lyme disease and a lot of mold exposures. So a lot of times the gut issue kind of fell within that. So that's a really long answer to your simple question.
I like the long answers because, I'm always listening for the key nodes in people's stories of what motivates them. And I've never met a successful person who's good at what they do who hasn't been driven by passion, but also influences in life that were very important to them. So I want to thank you for that, because I think that kind of stuff is infectious, the good kind of infection. You want to catch a little bit of that magic from people who are doing well. So you dropped the SIBO name. I'm going to keep doing that because I think it's hilarious. In your own words, if I can ask, what is SIBO? Because we know it's got an acronym. Functional medicine loves their acronyms, but how does Dr. Bush define SIBO?
Well, yeah, when I talk to my patients, it's, you have a small intestinal bacterial overgrowth. So you basically have an overgrowth of these bacteria that are supposed to be in large numbers in the large intestine, and they end up settling in large quantities in the small intestines. These are typically either anaerobic fermenters or archaea organisms that produce gases after they eat certain types of sugars. And so in the most simplest way you describe it is that they're weeds in your garden. And those weeds create gas, and they also poop out a bunch of metabolic waste that makes it feel bad. And so on a physician level, it's like, yeah, you've got an overgrowth of anaerobic fermenting bacteria in the small intestines that you're looking to maybe remove or displace.
Now, I've often wondered this. Is it simply population-based as a problem, or is it pathogen-based as a problem, or is it actually some amalgamation of both?
It could be both. By definition, these are critters that are supposed to be there, but they ended up, just like anything else, just taking over the area a little bit more. And the reason why could come from anything from a pathogenic cause like food poisoning, to just not having a diverse diet and eating lots of foods that end up feeding the weeds more, to having predispositions where you don't have proper digestion, you have disturbances in gut health, or, unfortunately, sometimes it's just with age because, sometimes you just collect luggage along the way.
Fair enough. And you just gave me a lot of things that I want to dive into in a little bit. But, people use the term SIBO in an umbrella context, and you just kind of delineated it's a scenario where the things that are meant to be in you have found themselves in the wrong place. Am I correct in saying that?
Correct.
And the industry has a perspective that it's only a bacterial problem, but I want to elucidate a little bit more. Is there such thing as SIFO? I've heard this term before, but I'd love to ask you what your opinion of this is.
Well, of course, SIFO is just a fungal overgrowth. And, it's interesting. I love the industry where once you have an acronym that's popular, there's so many branches that they have to like create off of it.
Oh
They
yeah, we
ride the
like things in boxes.
bandwagon.
Yeah.
But fungal overgrowths are always with us. I mean, what Candida and all of its little cousins and friends, they're opportunistic growers. So whenever there's disturbance, it's always going to be there to be part of the scenario. One of my favorite research studies kind of broke down the difference between people who have only fungal overgrowths, only bacterial overgrowths, or a combination of the two. And you're looking at a scenario where you get, about 50 to 60% of the time, it's a bacterial overgrowth. And then you'll have a small you'll get another like 20% when it's going to be a bacterial and fungal. And it's a small one out of maybe 5 people, one out of 6 people that might just have fungal. And so fungus is definitely something that you have to be aware of. It's so much more problematic, and why historically we've been tied to yeast issues with health, because the average person doesn't notice the fungal overgrowth until they get a massive, like, thrush, rectal inching, etc. But when people have mold allergies, like like a traditional allergy to mold, and then they get a overgrowth or even just a high level of normal candida, they start having not only the yeast reactions, but an allergy response to the yeast, which is an amplifier effect of symptomology. And so that has historically confused people and make people kind of keep going down this like fungal issue all the time. And don't get me wrong, I mean, fungus is definitely something that is among us and that you have to treat or address at times, but typically it's rarely the main issue. It's frequently treated pretty simply, naturally. The problems mostly come in when they have that allergy response to the molds. And then you get a very confusing symptom picture and an amplification of gastrointestinal and systemic issues. It's like, well, yeah, someone has to take a little bit of caprylic acid to get rid of the aches in their fingers. Yeah, well, you didn't have yeast circulating through your blood, but you sure did have an inflammatory response to that yeast in your gut.
So what you're saying is the immune system gets sensitized to the presence of the yeast and the metabolites they throw off. And I would imagine that could confuse a clinician because the presentation might not be the automatic association, i.e., oh, you're having a histamine response, you're having joint pain, you're having congestion, you're having poor sleep issues. So that really can compound things.
That's
What are
correct.
some of the parallels in terms of how SIBO and SIFO present common symptoms?
Oh, that's a good question. So when it comes to the presentations, you'll see the non-gastrointestinal symptomology just cross over. You'll get you'll get the joint aches, the muscle aches, the fatigue, the brain fog. You'll get the endocrine disruption. You'll get the skin rashes. All kind of cross over together. When you get you'll typically, like I said, though, the interesting part of it though is rarely are you going to see the fungus on its own. So many times people are giving the symptoms in the gastrointestinal tract credit by the yeast, but in all reality, more times than not, you probably have a bacterial overgrowth allowing for that fungus to then catch a ride in dysfunction. And then you'll get a combination where, yeah, you got some fungal action. And if you treat it, especially if you have a allergy to mold, you'll feel a lot better, but it'll reoccur. And it's that reoccurrence that you have to ask, because your fungus shouldn't reoccur unless there's a inhospitable environment for it to take advantage of. So then you go and say, well, all right, well, what's the common disturbance allowing for the fungus to be an opportunistic grower? And for, I would say 7 out of 10 times, you got to make sure at least you rule out a small intestinal bacterial overgrowth.
Got it. And I had this vision of when you said, they're opportunists. It's almost like there's a bacteria driving a car and there's a fungus sitting next to it in the front seat. But if there's 2 back seats, there's got to be something else that occupies it. I'm going to throw a curveball your way. Is SIPO a thing? I came up with this. You talked about people making analogies. Is small intestinal parasitic overgrowth part and parcel of this?
Well, it could be. I see more of the parasites in the colon.
Okay.
Maybe that's because more of our testing is geared towards the colon. But yeah, so we will frequently see, especially reoccurrent issues in the GI tract, high histamine states that have also gastrointestinal presentations, still having a possible parasite. And when we say parasite, almost everyone goes to the worst case scenario of wiggly, gross things that keep you up at night. But
like the movie Aliens, when it pops through your stomach.
Exactly. It's like, it doesn't have to be that nefarious in presentation. More times than not, especially in the Midwest and many parts of the country, you're going to see amoebas, protozoans, things that you get from swimming in lakes, from drinking water that's contaminated, having the fecal oral contamination in foods at your most popular restaurants, and traveling abroad, working overseas, things like that. We see that more often. Every so often, you get the wiggly thing too, because as much as we like to think that we're sterile and we're not part of the animal kingdom, well, it comes at us and surprises us every so often.
And the last one I'm curious about, because in my perspective, Louis Pasteur, even on his deathbed, said I was wrong. It's not the germ, it's about the terrain. So I think you'd agree with me in saying that the environment needs to suit the potential for these things to become reality, i.e. overgrowth of different kinds. What are your theories about how viruses play into this whole thing? Because we have so many inactive viruses in our system. And I've, in my studies and readings, I've learned that where there's one that attracts more. How do you factor in viral infections based upon A, your perspective of this, but also B, what you see clinically in presentation?
Well, that's a good one. Well, the most obvious thing to kind of draw from that is with the COVID pandemic. And it's interesting because earlier in the pandemic, we saw some GI issues, but it was definitely a much smaller percentage of overall problematic cases. With the newer strains of COVID, we've actually seen a higher percentage or more GI-related issues, both acutely with COVID, but also in the long-haul COVID. And so that kind of opens up a really nice idea of how viruses in our environment may be presenting in more of these chronic GI issues that we're not giving them credit to. Part of it is I don't think we know all the viruses out there. We keep learning about new viruses on a regular basis. I mean, we like to pride ourselves on being really smart as humans and scientists. Yeah, we're still pretty much neophytes on this planet, and we keep learning. Heck, we just discovered a whole new group of whales in the Indian Ocean. I mean, a whole whale species that's been around for eons.
We found a new muscle in the leg a few years ago in the quad area. We found a new organ in the mesentery in the gut, like 2015, 2016. Yeah. Do you ever get to that place where you know more than you've ever known and you feel like you know less than you ever have? Because you just come up with new questions rather than definitive answers?
Yeah, I'll always be reminded that I'll always forget more than I ever know.
This is a very good perspective. So thank you for kind of touching on, the major offenders, if you will, of the cell danger response and potential inflammatory threats. If a clinician were to ask you, Dr. Bush, could you help me understand how to delineate SIBO and dysbiosis? How would you separate and partition that out for them?
Oh, that's a good question. Well, by definition, they're the same thing. You just have a small intestinal bacterial overgrowth becomes a more severe or dysbiosis. But dysbiosis by definition is just an alteration of the normal microflora, and SIBO is one flavor of that. And by definition, you can quantify that through a breath test by how much hydrogen or methane gas is being produced in that small intestines. Likewise, you could also quantify it to some degree, because someone might meet the diagnostic criteria, but they don't have IBS symptoms. And you're like, all right, well, you got an overgrowth. I'm not going to say it's like it's a pathogenic overgrowth. I'm going to call it a dysbiosis, and we're going to do some tender loving care to help alter your flora more favorable. Probiotics and diet changes, things like that. Versus, oh crap, that's a massive overgrowth, and you've got a lot of symptoms that back that up. We might need to pull out some bigger guns, get rid of the weeds, so that we can get a better terrain settled, so that we can maybe fend off problems in the future.
And how do you go about diagnosing such a thing? Like, what are those diagnostics, those objective measures that you can validate, yes, this person has SIBO, and maybe what are some things that are not objective lab data that maybe a clinician who works more off symptomatology can cross pattern?
Sure. Yeah, I mean, with my own patient base, I mean, we're going to do a detailed patient intake, because your symptoms will start painting a picture. They're your breadcrumbs. So your gas, your bloating, your diarrhea, your constipation, possible heartburn and GERD. Do you have any type of muscle weakness, fatigue, achiness, exercise intolerance? Do you have any rashes, rosacea, things on that order? And then we'll do an abdominal exam. We'll examine a patient. Do they have trapped gas? Do they have bloating? Is there tenderness? Is there point tenderness, diffuse tenderness? Is there a hiatal hernia present? I look at those things, and those are all kind of painting the picture, because if you're a bacteria producing a boatload of gas, well, it's going to leave a mark, right? Or at least something to track. And then we'll often, if they meet some simple criteria, we'll have them do a lactulose or glucose breath test. And that's a challenge test where a patient will do a prep diet for 1 day if they have diarrhea or no issues with their stool, or 2 days if they have constipation or really slow gut motility. And then they'll fast overnight. They wake up in the morning, they do a baseline breath collection, and then they drink the sugar solution. Set their timer to 20 minutes, and every 20 minutes, they collect another breath sample. Those breath samples are your air coming out. And what's being measured, my laboratory at Nuerovanna, we measure methane and hydrogen gases. We use a gas spectrometer for that. And if you're looking for, in hydrogen's case, an increase of 20 parts per million of hydrogen in that first 120 minutes of the test. If it's methane, you're looking for the presence of methane of 10 parts per million or greater in that first 120 minutes. And so we do that. When it comes to other clues that you might have, some of the testing, sometimes I look at a person that's like, well, I'm not really sure I want you to put you through the challenge, the prep diet and the test right off the bat. And so I might even do like a blood test. And in a blood test that we do, I often will measure myeloperoxidase, which is came to market as a cardiovascular marker for blood vessel integrity, but it's a wonderful marker for gastrointestinal or other imbalances where neutrophils migrate to. So we see that as a nice screener in cases where I'm not really sure.
Meaning likewise, it being high is your clue? Myeloperoxidase
it being high, yeah. High myeloperoxidase is an enzyme produced by neutrophils, and so it's a active measurement of them going somewhere and acting upon it. The biggest false positive for the cardiovascular world is IBS GI issues. Go figure.
Interesting.
Yeah, go figure. And And honestly, it's like you have to have pretty advanced cardiovascular disease for that NPO to be high for cardiovascular purposes. Likewise, you get patients that have chronic iron deficiency, chronic B12 deficiency, and other nutrient deficiencies that are unexplained. And so, you'll see those pretty classically. I mean, when you look at, if you're not doing blood work or other testing, some of those non-lab-based testing would be abdominal exam, bloating, gas, belching, things on that order. You also have, like, a person has leg cramps. All right, well, leg cramps is a good indicator of possible magnesium deficiency. And when in doubt, right? I mean, that's who everyone goes to first. And that works most of the time. But the question is why is their magnesium low? And when it comes to mineral absorption, chronic cases of small intestinal bacterial overgrowth will interrupt that absorption by a lot. You don't notice when your chromium or your molybdenum's low, but you notice when magnesium's low, and that's usually the first indicator. And so those are all good things. And in addition to that, you may have them telling you every time I eat these certain foods, whether it be like dairy or grains or gluten, certain avocados or apples, and they just like get gassy, bloaty, diarrhea, constipation, what have you. All right. And then likewise, I have a lot of patients where they're referred to by dietitians because the doctor tells them they have IBS. They put them on a low FODMAP diet. They do better, but they can't get off the low FODMAP diet, and they still have like a lot more symptoms going on. And so those are all good indicators that there's a small intestinal bacterial overgrowth.
I mean, that's incredible because it gives us different avenues to explore based upon your style of practice. And I'm sure practitioners reach out to you all the time to get involved with, commissioning lab work through you. So that'll be something that we can talk about at the end. You said a couple things. First and foremost, so you drink a sugary solution prior to your breath testing. So you found a purpose for Kool-Aid. I didn't think that was a thing. So nice to know. The second thing I wanted to ask, you mentioned systemic dysbiosis and you mentioned IBS. In your opinion, does SIBO always lead to systemic digestive dysbiosis? And does it always accompany, or I should say, does IBS always accompany a SIBO-like presentation?
When you say systemic IBS, what are you referring to?
Systemic dysbiosis. Dysbiosis was, SIBO is dysbiosis, but colonic dysbiosis is not SIBO. So
Correct.
Does one, i.e. SIBO, always lead to the other, systemic dysbiosis?
Got it. Okay, so it's a two-part question. Okay, so the first part would be you can have a SIBO without having a colonic or large intestinal disturbance. Is it common? Yeah, not the most common, but it definitely can happen. It depends on the root cause of the dysbiosis. So, SIBO in itself is rarely the main root cause problem. It oftentimes will be a result of a root cause. So that's important. You get the person who has a classic acute gastritis, so food poisoning. That person, they may present and their testing shows everything's normal, and then all of a sudden they reach a certain point in the small intestine, you see this big blip of activity, and then it goes back to normal. All right, well, that's textbook. Whereas you see more commonly, you'll see people where they've actually had a long-term maybe maldigestion or an abuse of eating wrong foods. And you may see a very normal digestion or a slow increase, normal bacterial load or a slow increase in bacterial load. And then it kind of reaches a threshold in that small intestines. And for a lot of people, that could be in the middle of the small intestines or towards the distal end of it. And then it will continue in the large intestine. For some people, depending on the issue may be in the large intestine, whether it be because of an ulcerative colitis or Crohn's. It could be because of a parasitic infection. And then that actually causes the large intestines to be a dysfunctional environment. And of course, it's supposed to be a fermentation vesicle. And that in itself can become overgrown, and then it spills over in the small intestine.
Via the ileocecal valve, right? It kind of
Pops past the ileocecal valve and party on. And so you just it all depends on that root cause. I mean, you'll get some patients where they have a lactose intolerance or a dairy sensitivity. And here I'm in Minnesota next to Wisconsin. It's like, I'm not, my cold dead hand on my cheddar cheese, I'm not going to give it up for no matter what. And you do a test and their levels are sky high from start to finish.
Mm.
And it's like, well, yeah, if you're not properly breaking down your food and your sugars, it's basically wonderful fertilizer for all the wrong bacteria for over a long years and years of usage.
Well, that's such a great insight, and it dovetails or segues nicely to what I wanted to talk about in this, in that I think people sometimes get fixated on the SIBO, and it's, throw hell, fire, and brimstone, every destructive herb under the sun, and let's make our small intestines look like that of a germ-free mouse. But if I'm thinking through this, the small intestine does many things. It's a surveillance site for the immune system. It is a major digestion site for what I call the final phase of digestion. So if we're not digesting our food and we're bombarding the small quantities, in small relative terms, quantities of bacteria in the small intestine with undigested food, what is that doing? Like, what is lack of stomach function, lack of pancreatic, and I really want to know what you think about gallbladder function and the role of bile in terms of the development of SIBO. What is digestion and lack thereof doing to our small intestine?
Well, I mean, it's allowing for, basically the analogy would be like nitrogen runoff from the farm fields into your aquifers. It's just giving wholesale fertilizer for the environment to grow in, and it's favoring these fermenting bacteria. So it provides a great opportunity to develop dysbiosis and fungal, whether it be bacterial or fungal, on a regular chronic basis. So if without proper digestion, you don't have a healthy GI tract. So people with reoccurrent issues, that's one of those things you always have to address, because just like anything else, it all starts in the very beginning. And if you're not chewing your food, if your hydrochloric acid is not being produced, if you don't have proper bile and pancreatic enzymes and a nice lush brush border that produces enzymes, well, you're predisposed to having problems. And of course, it doesn't have to be perfect. The human body was designed in a wonderful way to be adaptive, and we can abuse it quite a bit and it still functions. But there's always a tipping point, and there's predispositions. And not everyone's George Burns, who could drink until he's 100.
All the cigars he smoked, incredible.
All the cigars. I mean, hey, he made a lot of glutathione. Good God bless. Some people can eat. They eat whatever they want. They never have a GI issue. Some people they stray away from organic foods, salads, and salmon. They'll die. And it's like, well, wait a minute here. So, but that happens, and you get people with mast cell issues, histamine issues from chronic long-term dysfunction, and then you get this amplifier effect of sensitivity, sensitization, and dysfunction upon dysfunction for them, and it just makes their life more miserable, and their quality of life takes a spiral down. And then you mentioned about specifically in regards to bile. And and bile is a very important thing. So when I first became a practitioner or a doctor, I practiced in New Hampshire, and I was told a long time ago, hook up with the old doctors in an area to find out what's more common locally, so you don't miss it out. Since I didn't grow up in the area, I grew up in Chicago, and so the first thing that the old practitioners in the neighborhood said is like, well, if you meet anyone over the age of 60 with a gallbladder in the New England states, that's a rarity. Because the gallbladder surgeries were started in the Boston region, and well, they did a really good job to make sure no one had one. And of course, then on top of it, the clam bakes and the donuts and the fried foods didn't really help. With that much said, your bile not only helps you with proper digestion, so pulling out your fats from your GI tract to limit the diarrhea and to help normalize function, it's also well established to be a bacterial static that helps sterilize and helps prevent the adhesion of bacteria from those walls, especially in that upper small intestine, which is very critical because the small intestines has a small amount of bacteria to keep itself protected and clean and help absorb nutrients versus the fermentation vesicle known as the colon.
Awesome. I mean, that is the one thing that I think many people need to hear. Because if you don't have a gallbladder, you probably need to have some contingency plan to prevent SIBO from something in your future. But putting it all together, I always say there's an underappreciated role of digestion in terms of the fact that it's not necessarily the most exciting topic and it's a little nuanced, it's a little dry. But if you don't understand the process of digestion as a practitioner, even if you do nothing else, by helping someone improve their digestion, you will fix some degree of most things that are going on, or at least provide the body with the ability and the energy to fix itself. I want to shift gears here with you because, we've gone from a lot of theory. I kind of want you to put your clinician cap on because I know you're still at the office, and get into some of the strategies about thinking through the process of addressing SIBO. But I have a very interesting question. In your opinion, what do you think most people neglect or do wrong when addressing SIBO?
Oh, wow, that's a big one. Well, one, on the philosophical side, they think of things as black and white. So you can't just think of it as a nefarious creature that you must mow down and kill off, and then everything's going to be great. It's weeds. So your weeds are in the garden, your microflora out of balance. So you have to critically think, why is this the case? Because when you treat it, how are you going to prevent it from coming back? Or the idea that it may be the canary in the mine shaft. Well, all right, you got this going on. Well, what is it telling you about your health? Okay, so that's the first one on the front end, because people get so excited they just want to go and mow down weeds and be happy. Okay, number two would be oftentimes they're using treatment approaches that have no research efficacy, and they basically don't test with a breath test either before and or after. And they basically they treat on assumptions. So they're assuming this therapy, I was told, that works, therefore it has to work. And if I use it for said period of time, it must work. And if it doesn't work, then it can't be SIBO anymore. It must be something else. And that is treating on assumptions. It's diagnosing on assumptions. We don't assume what people's cholesterol levels are or glucose levels are. And we don't put a treatment in to be aggressive and change the body in some way without then rechecking it to make sure you actually achieved your goals. So that would be my two things, which is like a few different items thrown in at one time for you.
Yeah, it matters because, one of my mentors once told me, I can tell you the information you need to learn, but I can't teach you how to look at it. If you develop perspective, that is one of the greatest tools you can ever use in any situation, because there's knowing what you're looking at, but there's also knowing how to look at it so you can hopefully increase the likelihood of success outcomes. I'm really interested to know if someone were to ask you, Dr. Bush, I got 5 minutes, 10 minutes, show me or teach me how you think through the process of addressing SIBO. What is the holistic global view of how you would get into not specific supplements and doses, but the thought process to help guide people towards success, as much as you willing or you can share?
Well, okay. Well, that's a big one. So it's not a master class for 5 hours, but all right, I got 5.
You just did that.
So, all right. So with that much said, it all starts with the intake and appreciate how they got where they are.
Mhm.
You know, is this something from day one in their life? Is it something that they acquired when they were a teenager? Is it something that happened like a couple years ago? So you need to have an appreciation of when and how it's scaled in intensity and in symptoms, because some dysfunctions as they go will just gather more dysfunction.
Mhm.
And so that helps you identify how long a disturbance might have occurred, why it might have occurred, and making sure you're not missing out on investigating other things. So a good example is like, hey, someone's like, I've had gut issues since I could remember. Now, I remember as 8 years old having tummy aches. Well, all right. Well, you know, was there a disturbance at 8 years old that occurred? Or is there a family history that has similar issues? And that may paint a picture towards digestive insufficiencies that have been inherited, or gluten hypersensitivities, allergy sensitivities. Or was it because you had exposure to something when you were young and there was a point in time it started, not just a slow progression? Likewise, it's is you know, especially with in women, if it starts happening right when their cycle starts, hormones kick in, and all of a sudden their GI goes south on them. Well, one thing I've learned is never underappreciate how horrible a hormone imbalance can be for the health of a woman. And it oftentimes will just be, you know, said, oh, you know, it's not that big of a deal. Or, you know, they just gets brushed over. He's like, no, let's focus on the GI. Well, all right. Well, the GI may be still an issue, but if there's a hormone component, whether it be like a polycystic ovarian syndrome and endometriosis, or just a massive estrogen imbalance, well, that could mask a lot of things and cause a lot of those same problems that then you're attributing only to the GI or digestion or what have you. But it's a whole different avenue to go down. And so it's just a respect factor that often in the GI world doesn't get very much press or appreciation. Later on, it goes into like, hey, did you eat at Jack in the Box and have a problem ever since? Did you go camping and never have normal stools? Did you travel overseas, etc.? Was it a flu or some weird infection that occurred? Those are important. Or it's one of those things where it's like everything was going well, I was doing well, and then in my 30s had a lot of stress, drank a lot, was eating a bunch of crappy foods, didn't really appreciate whatever, and then I got bad, and it's been bad ever since. So many different avenues there, but you have to ask, you have to take the time to go through that the minutia in that, because it saves you so much time, the patient so much money and time on the front end. After that, it's identifying, well, what is the symptoms and problems, and then triage what it might be, because when people are complex or have lots of problems, it becomes like a Venn diagram of overlapping problems. So you might need to pull things apart a little bit, you know, the classic peeling the layers of the onion off, because when everything's piled on top of each other, it's really hard to know what the root cause is. And there may be multiple root causes. So at that point, you start triaging what your issues are. And of course, on the front end, it's easy to start helping with digestion. If you have classic symptomology, that's gas and bloating, diarrhea, constipation, IBS centric, well, you're going to do a breath test to rule out the SIBO. If not, you may think about doing a stool test or a food sensitivity test, or you do certain treatment trials.
And where do supplements come into the picture once you've identified all those things? So you do an incredibly detailed intake, you do your diagnostics to qualify and quantify what you're dealing with. How do you go about deciding what supplements are most useful? Because we've talked about, just throwing every herb at the gut is probably not the way to do it. What are some of your greatest hits or some of your greatest tools?
Well, sure. Well, I mean, all depends on the problems. When it comes to SIBO specifically, I mean, there's one very good published research study on herbals and SIBO. Most and so it was done a while ago, so I'm sure there might be better products maybe on the market now, but there's only two products that have been done in well-designed study. It was published by Johns Hopkins. It has a decent number of people in it, and they showed good efficacy. So great. So I just based my treatment protocols on those because, well, there's smart people out there that have done the work. And a lot of companies I've seen piggyback on that a little bit, and they quote unquote make a better alternative, but they don't have any efficacy showing that it is efficacious. They might have clinical write-ups or something that they paid to have done, but that doesn't really, that doesn't to me pass the mustard for a lot of things. Mm-hmm. The IgG. Oh, I'm sorry. You should do the IgG. Yeah, IgG.
You really are in the clinic. Look at
you
multitasking.
And so the protocols I use are based on that. They've been modified. A lot of good practitioners have kind of helped improve upon algorithms for this. Dr. Seibecker, Dr. Sandberg-Lewis expanded on a more integrative approach that Dr. Pimental started in the gastro world. And so those people have done some brilliant things, and we could learn from those. And guess what? Clinically, a lot of that works. So using some published guidelines, adding in some nice time-honored and clinically proven treatments help. But, just using, just because a company says they have a product that works for SIBO doesn't necessarily mean it does. It can. There's nothing magical about the research proven ones. They were old anti-candida and parasitic protocols that they used for the treatment protocol. And so, that other things work for it. And guess what? People have been treating gut parasites and dysbiosis a long time. And those traditional herbs, oftentimes the ones that worked more frequently, worked against the SIBO, the anaerobic fermenters. And that's why they become more popular, because intellectually, once again, when someone does something like an anti-parasitic protocol and it works, it must have been a parasite that I killed. Well, not necessarily. You use anti-parasitic protocol and you change something favorably. And we see that all the time in a lot of these antimicrobial protocols, not only with gut issues, but then with infectious diseases, whether it be people treating tick-borne illnesses or whatnot. And just because you're using it for said purpose doesn't necessarily mean that's what it's working against. So,
the outcome may come nonetheless.
And the outcome, and people are, hey, as long as people get a good outcome, that's great, with least amount of harm and highly efficacious. But it always makes me I don't like practicing where you throw the kitchen sink at someone hoping that it works.
Yeah, there's a more strategic way to go about it. I have one more question I want to ask on the clinical side before we start wrapping things up. Where do probiotics and systemic enzymes come into the picture in your mind in this whole thing?
Probiotics and systemic enzymes.
Yeah. So I would imagine with probiotics and SIBO, you may not want to give someone a probiotic when there's an overgrowth, or would you, based upon what that probiotic does? What's your philosophy there?
There's a tipping point. So when someone has a dysbiosis and it's not really pathogenic in nature, more times than not, you can use probiotics to actually make a more favorable environment to get rid of the dysbiosis. So when and of course you could do that with fermentable foods sometimes, more like your highly cultured yogurts. But you could also, but the probiotics are wonderful at doing that, and that's where some of their biggest strengths are. Like, why wait until your garden's filled with weeds before you start treating it? So, for the average person, for maintenance, it becomes an indispensable tool. So post SIBO, if you do a SIBO treatment, I don't use them in the herbal phase because I'm using a bunch of herbicide that's going to kill those bacteria. I will use them post herbs to help reseed and create a favorable environment for at least a minimal 1 to 2 months, or many people, depending on their history could be a long-term scenario. Likewise, if we do antibiotic therapy for patients, we're always going to be using a probiotic away from the antibiotics and a Saccharomyces with the antibiotics because, and of course, this is, some people will say, well, you can't use a probiotic when you're with SIBO. It's like, well, the research is pretty solid. You use a probiotic to prevent adverse events with antibiotics. So don't go into the minutia details about, is it really good for bacteria or not? No, it's good for your health. And if you're going to use something like an antibiotic that's not a multivitamin, you're going to want to just stick with the research and be protected. When it comes to systemic enzymes, the best use of systemic enzymes in the land of SIBO would be to help with biofilms. And so people with more reoccurrent SIBO, long-term SIBO, there could be a great benefit with seropeptidase and other really potent systemic enzymes to actually break down those biofilms, which in research they've been shown to do really well. Likewise, I'll also use systemic enzymes when the people have a lot of those muscle aches, bone and joint aches, secondary to the bacterial overgrowth, but also to other particular reasons. I find great use for them, in addition to obviously clotting issues in general.
Amazing. I mean, we could probably keep going for a while longer because there's so many questions that are popping up in terms of understanding nuances of inflammatory responses in the immune system as you're talking. But I do want to respect your time and the time of everyone who's here. I did want to ask a quick question because someone popped a question through in the context of understanding extreme fatigue after eating. Would you say low HCl or SIBO and or others? What would your gut response?
Oh, yeah, that could be. Yeah, there's so many reasons there. It's a common occurrence. Let's just say that. And you know what? Yes, all the above, plus, your digestive enzymes, your yeast activity, your food sensitivities, all those. So basically, you have a disturbance in the body, and it's sucking your energy. And you know what? Unfortunately, your body's not so simple to have a simple answer. And many of those disturbances and root cause problems have similar symptoms, and that's a good example of it.
That's awesome. Dr. Bush, I know there are people who are probably very curious about learning more from you, learning more about you, and potentially connecting with you to commission some of the testing that you do. How can people find out more about you? Where can they find you? Is there a website they can go to? Is there a contact person that they can reach out to?
Well, sure. Well, you could. My laboratory that runs breath testing is the Nuerovanna company, and so Nuerovanna could be reached. You just do a web search, Nuerovanna breath test, you'll find it. We service practitioners. If you're a practitioner, we're happy to have your business. We're a mom and pop company that specializes in just the breath testing. It's the laboratory is out of our clinic. We will treat your patient's breath specimen just like we treat our own patient's breath specimens. And we're always available. Myself, my wife is the other doctor on staff. That's a SIBO expert. We're both available for interpretations and to help doctors with difficult cases, or to help understand the whole process a little bit better. And I help patients doctors and practitioners on a regular basis get a better grasp on how to address and manage overgrowths in that regards. Likewise, as a practitioner, I practice out of Minnesota. I'm still a full-time practitioner. We're at the Natural Medicine of Stillwater at stillwaternatural.com. And I see patients all around the world for different issues, whether it be for neurological brain gut issues, mood disorders, chronic GI issues, what have you. We're happy to help people out whenever possible, or refer you to someone that's local. But those are the ways you can reach me. Hopefully you have good health and you don't have to reach out to me.
But if someone wanted to, you'd be happy to sit down and talk to them and guide them through the process of testing. And I know you're fairly active on the speaking circuit. Are there any big events coming up towards the end of this year or next year that you think any practitioners would benefit from going to? Would it be worthwhile to make the trip?
Well, I mean, there's always good conferences going on. I'm going to say that we'll be launching a podcast on our Nuerovanna website by the end of the year. So feel free to check in on that and sign up, so you can also get some good information for not only SIBO but also CAM, or complementary alternative medicine in general.
Awesome. And the final thing, is there anything that you want to leave all the practitioners who are watching this live today and the ones who will probably watch it when they get off work later tomorrow? Any final message, Dr. Bush?
Well, first off, just remember, when you're working with people's GI tracts, that's their sacred garden. So treat it like you'd want to treat your own, and think big picture. Think the fact that, hey, you're going to have to get a better point of health. When people see doctors, it's usually because they have bad issues. So oftentimes the doctors need to use big sticks to get rid of that. And that's where you get the SIBO, you get the parasites, the IBS, IBD issues. But in the long term, your treatments are not just aggressive. Think about the tender, loving care it takes to raise and nurture an organic garden. And that's sort of the big picture that you need to be left with when it comes to how to address a patient for the long-term success. That's where I'm going to leave it at.
That's awesome. That concept of nurture comes back around from the beginning story of your mom, nurturing animals back to health in the house. It seems that that's infected your perspectives of how you want to help people and what it is you want to do. It's probably why you have so much success. So I want to thank you very much for your time, for your expertise, for letting me throw so many random questions at you and taking them in stride and answering really well. Appreciate you being here.
Thank you, Roland. It's a pleasure being with you.
All right. We'll talk to you soon. Have a great evening. Thank you, everyone. We'll see you guys soon.